Welcome to the series of lectures in oral medicine, this one entitled Biopsy Technique and Diagnosis. Some of the biopsy types used in oral medicine include smear, swab, used for cytology, incisional biopsy, excisional biopsy, fine needle aspirate, and core biopsy. There is further information on this on the SDL help slide. So when we in the clinical situation, once we have done the history examination, sometimes special tests are required to come to a definitive diagnosis. And here we are in this slide, we're looking at swab, smear, imprint, and oral rinse. Swab is where you can take a sterile cotton bud and apply to the area of the lesion to get the surface cells. It's easy to use and site specific, but it's not quantitative. A smear is where you get a sterile spatula, scrape the area that you want to examine, and then you smear it on the slide, followed by staining with specific stains. For example, in this situation, if we are looking for Candida, then you would use PAS staining, and what we're looking for is Candidal hyphae, which are these strands that you can see, and these are the spores of Candida, but the presence of hyphae indicate that there is an infection. So this is a good technique for diagnosis of candidosis. The imprint technique uses a sterile foam pad, dampened and held on site for 30 seconds, and then put into a medium, and then to see what grows. With the oral rinse technique, you use a phosphate buffered saline solution held in the mouth for 60 seconds and collected in a universal compartment, and then used to inoculate a primary medium. Fine needle aspirate and brush biopsies give a little bit more information. A fine needle cutting biopsy is uses a wide bore needle, and it is used to gain tissue from a solid mass that's not as easy to access, and then that is put on a slide and the cells are looked at under the microscope. Fine needle aspiration biopsy is you use a 22 gauge needle to aspirate fluid, etc. for cytology. So this is where you have a cystic lesion, for example, in previous times, an odontogenic keratocyst or keratocystic odontogenic tumor where it's fluid filled. This technique was used for diagnosis of keratin content. Brush biopsy uses a cyto brush to reach deeper layers, so a little bit more than a smear, and it cuts in a little bit slightly deeper, and allows evaluation of slides using a computer-assisted image analysis. There's a high cost and high false negatives associated with this technique. So here's an example of a fine needle aspirate or core biopsy, where the area that we're going to penetrate the skin is sterilized, and then the needle is inserted, and it's moved back and forward, and what happens is the tissue gets embedded into the needle, and some of it will come into the syringe as you're creating a vacuum by pulling on the syringe handle, and then this is droplets are put onto sterile slide, which is then smeared and then stained, looked at under the microscope. Any residual material is then put into a medium, centrifuged into a solid block, and that can also then be mounted and looked at under the microscope after sections are cut. Incisional biopsy and excisional biopsy. Incisional biopsy is where you take part of the normal tissue and part of the lesional tissue, whereas if you have if the lesion is small enough, then you might carry out excision of the whole thing called excisional biopsy. So here we've got a red-white lesion, and the area is injected with local anaesthetic, and then we place a suture line anterior to the lesion, and that allows good control of the area, and also you're not having to use tooth forceps over the lesion, which could create artifact or damage to the area of the tissue that we're trying to look at under the microscope. And then with the scalpel, you take out an elliptical piece of tissue. Then once that's done, you're left with a defect which needs to be sutured, and once it's sutured, that heals quite well within a week or so. And then with the specimen, you can either put the full specimen into a formalin jar, or you can divide it and put a fresh specimen into saline and the other part into formalin. The formalin specimen will be used for histopathology, and the fresh saline specimen will be used for immunofluorescence. This is particularly useful when we are looking at vesicular bullous lesions to carry out immunofluorescence to create the diagnosis. So these biopsy specimens are then put into the fluid, make sure that it's well into the fluid, not allowed to dry out, and then sent to the lab. You fill out your lab form, and you use and label the two different jars as 1 and 2, or A or B, and making sure that you write down exactly what you want. And in this area, in one area of the form, you might write the history and what you have carried out. So basically, in this situation, there's an adherent white plaque here. You take a biopsy, put it into the pathology specimen jar. It's taken to the lab where they process it into stains and slides, and then that's looked up under the microscope, and this is what we see when we're looking at it under the microscope. Thank you.